The views you are about to hear are not necessarily the exact opinions of the participating physicians. They are expressed as differing points of view in this unique medical education setting, exploring best practices in PH patient treatment.
We'll now bring this case to order. I would like to welcome everyone to today's episode of Holding Court, where we are placing on trial the question of whether patients with a mean pulmonary artery pressure of 20 to 24 millimeters of mercury should be treated medically in accordance with current indications for those in whom mean pulmonary artery pressure is greater than 25 or equal to 25 millimeters of mercury. This has been an issue that was raised years ago and was carefully considered by the 5th and 6th World Symposia on Pulmonary Hypertension. It would represent a significant change in criteria should we move in this direction, so the case needs to be considered carefully. In an evolving therapeutic environment that has emphasized earlier and more aggressive treatment for pulmonary arterial hypertension, the question of what cut point in mean pulmonary artery pressure should be used to establish the diagnosis is of great import. I am Dr. Sean Studer. I will be presiding in this case, and we are fortunate to have two doctor attorneys who will also be trying this case, Dr. Richard Chanock and Dr. Valerie McLaughlin. We also have two expert witnesses they will call to argue the evidence here, with the goal that you, the jury, will ultimately render the appropriate verdict under the law. And we'd now like to hear our opening statements, beginning with Dr. Richard Chanock.
Thank you, Your Honor. It's a pleasure to be here. My side today is, I think, a fairly strong one for treating patients with a mean pressure of 20 to 24. First of all, we have to think what's normal. And I think there's a wealth of data over many years, decades in fact, showing that a pulmonary artery pressure of 20 is abnormal. In fact, normal pressure is well below 20, maybe closer to 12 to 14. We also know, and there's data to support this, that patients do have exercise intolerance when their pulmonary artery pressure is in that 20 to 24 range. And with exercise, the pressure goes up even higher. So this is not a normal response. We have exercise data, cardiopulmonary exercise testing that confirm that these patients who are limited have pulmonary vascular limitation. So even pulmonary artery pressures of 20 to 25 can limit a patient's ability to exercise. And in fact, we also have data that these patients can get worse. And over time, patients can progress. So it only follows, and I think we'll prove our point, that giving therapy that will modify this disease earlier on in the course of the disease is going to be more likely to delay or prevent worsening. It's certainly easier to prevent the arteriopathy and the abnormalities than to try to reverse them once they've already occurred.
Thank you, Dr. Chanock. Dr. McLaughlin, would you like to provide us with your opening statement?
Thank you, Dr. Studer. It's a pleasure to be in your courtroom today. You do look quite dapper in the judge's robe.
Thank you. Those were comments that Dr. Chanock was remiss in making, so I appreciate them coming from you.
My pleasure. So I do agree with Dr. Chanock that recent publications have demonstrated that in the majority of patients, the majority of subjects, the mean pulmonary artery pressure is less than 20. And in fact, a pressure between 20 and 24 may not fall within the 95% population distribution that is generally accepted as the normal range. I do agree with that. That does not necessarily mean that in the absence of data, such patients should be treated. In fact, many of the studies that I anticipate my opponent will show will demonstrate a reduction in exercise tolerance and an increase in mortality as the pulmonary artery pressure increases. However, these data are tainted with a very mixed population. Many of these patients have other comorbid illnesses, such as underlying left heart disease and lung disease, that may contribute not only to their elevation of pulmonary artery pressure, but to their symptoms and potentially to the reasons for the increased mortality as well. In fact, the positive correlation between the cardiopulmonary comorbidity and the mean pulmonary artery pressure are likely due, in fact, to the underlying disease. In different conditions, a mean pulmonary artery pressure has been associated with a higher risk of mortality, but there's absolutely no data to suggest that lowering the pulmonary artery pressure will lower the mortality. In fact, if it's due to the underlying left heart or lung disease, we wouldn't expect an improvement in outcomes to occur just by treating the pulmonary artery pressure. And in fact, there are other situations in which we might make those patients worse by treating them with PAH-specific therapy. I think the crux of the decision here is going to be based on the evidence. And the strongest argument that the con side is going to make is that all of the currently FDA-approved therapies for pulmonary arterial hypertension have been studied in patient populations with a mean pulmonary artery pressure of greater than 25. If one is to practice evidence-based medicine, one cannot apply such clinical trial data to a population of patients with a lower mean pulmonary artery pressure. Thank you, Your Honor.
Thank you, Dr. McLaughlin, and you, Dr. Chanock, as well, for your strong opening statements.
Strong opening statements from Drs. McLaughlin and Chanock. Please watch the next episode to see the questioning of our first witness, Dr. Richard Chanock, on the witness stand.